by Cicely Saunders. It's a free monthly seminar with speakers presenting on a range of palliative care and rehabilitation-related research topics. This series aims to optimize opportunities for local, national, and international networking within palliative care and rehabilitation. And today we have Dr. Steven Vanderstichelen, sorry for butchering your last name, as always, who is a postdoctoral researcher at the End-of-Life Care Research Group at Vrije Universiteit Brussels and Ghent University, and also the research coordinator of the Compassionate Community Center of Expertise. His research focuses on volunteering in palliative care, compassionate communities, schools and workplaces, and death literacy. And he will today have a presentation on the complexities and challenges in public health palliative care research. So Stephen will present for 40 minutes, and then we will have 20 minutes for questions. And if you do have a question, you can put it in the chat. We will record this seminar as well, so please don't try to record it yourself. And with that, I'll leave the floor to Stephen.
Thanks, Thais, for that introduction. And good afternoon, everyone. I'm really excited to talk to you all today a little bit about public health palliative care research, what some of the complexities and challenges are, but also what kind of are the research designs that are often used, that are appropriate, or that can be applied, and how to think about them. But so let's just dive in. Oh, my arrow key is not working. Let me see. Yep. So what is the public health research approach to palliative care? So as a clinical practice, palliative care has traditionally focused on the medical and nursing interactions between individual patients with their family carers and professional caregivers on the other hand. And so palliative care research is therefore predominantly focused on clinical and health services research, right? And until relatively recently, at least, has predominantly painted a medicalized picture of care or caregiving for the seriously ill or at the end of life. So public health and public health perspectives are interested in two important things. First is monitoring population health and the structural, social, and environmental factors that influence the population health. And on the other hand, promoting population health through prevention, early intervention, and harm reduction initiatives. And so applied to the end of life and palliative care, public health research is interested in both monitoring and improving the structural, social, and environmental circumstances of people faced with serious illness, death, dying, and loss at a population level. And so its focus is on communities, but also the social and economic determinants of health and the impact that policy changes may have on population health. And more than just focusing on certain patients or patient populations identified based on service use or biopsychosocial risk, public health perspectives are focused on the full relevant population. Now, what is the full relevant population? That's you and me. That's all of us, right? That's everyone who will ever come to die or come to be a family care or an informal caregiver, or who will face serious or chronic illness themselves, or who will lose someone close to them. So that's really all of us. So public health research is interested in the entire population, basically. And within public health research approaches to palliative care, there's two broad approaches that are generally recognized, and often they're referred to as, on the one hand, the traditional public health research approaches, and on the other hand, the new public health research approaches. Now, I've put those terms, traditional and new, between quotation marks because I don't think they're very meaningful nor accurate denominators, but they're often referred to as such. Traditional seems to imply, at least to me, when you call something traditional, that it's kind of outdated or conservative or no longer relevant, and that's not the case at all. It just has been around longer. So to that extent, it's an accurate term. It's been around longer. But new is also not accurate, as they're no longer new, nor are they better or more relevant or replacing traditional public health approaches. Both of the approaches are quite complementary to each other, really important, doing really important and current research, but they do depart from very different epistemologies, right? So traditional public health research approaches start from post-positivist epistemologies. So whereas the positivists rather say that there's an objective truth and we can know it, the post-positivists don't go so far, but they say, okay, objective reality exists, but it can only be known indirectly. And so there's an objective truth, yes, but human knowledge is fallible and based on conjecture. And so therefore, we keep researching, we keep on further investigating, and that can lead us to modify what we know about reality. And within this broad stream of research, we find predominantly quantitative and epidemiological studies that monitor and assess the circumstances, social challenges, planning services, and policies around serious illness, death, dying, and loss. And topics are wide-ranging, of course, but some of the prominent topics include quality of care, quality of death and dying, end-of-life decisions, care setting transmissions, place of death, prescription and deprescription practices, healthcare costs at the end of life, and service use. And we'll see some examples of such studies. The new public health approach, on the other hand, departs from a social constructionist epistemology, and that proposes that certain ideas about reality arise from collaborative consensus rather than pure observation of reality. In fact, there is no objective truth, but individuals and groups help create reality, and truth is therefore constructed and maintained in social interaction. And that is also why you'll see a lot of new public health research approaches use participatory action methodologies. And these studies often emphasize a pursuit of equity and access to palliative care, attention to the role and social and environmental environmental factors in population health outcomes, and topics again far-ranging, but include social relationships, social networks, community engagement, volunteering, environmental and social determinants of health, support networks in end-of-life care, the role of public institutions in health promoting palliative care, death education, and so forth. These approaches developed from the community engagement movement. And so these approaches are, unlike what the term says, not new, but they're new in the sense that they have previously not been applied to public health palliative care research. And they emerged in part in a response to a growing criticism of traditional public health approaches to palliative care. And that criticism says that the traditional public health approaches reinforce the dominance of healthcare professional perspectives, and that such a dominance of those perspectives focus on professional services. So the focus on professional responses serve to disempower communities. And by doing so, placing further demand on health services and something that is considered untenable and feasible going forward. So what kind of designs or research designs are appropriate or possible in public health palliative care? Now, research designs can be classified in endless ways, and not one of them is definitive, exhaustive, or infallible. And I'm going to propose you one myself, and it is neither of these things either. But you can classify research designs based on combinations of ontology, epistemology, but you can also classify them based on data types, study populations, data collection methods, or any combination of those. So it can be quite daunting to categorize or try to categorize research designs because you can do it in so many ways, and there's really no, like I said, no definitive way, and they all break down at some point. However, I do find that a particularly helpful way of considering research designs for public health palliative care research is by dividing them into these three groups. That, as we will see with each category, and these are not ordinal categories, it's not the case that one is better than the other, but they do increase in complexity. And these are observational designs, experimental designs, and change-oriented designs. Now, observational research designs, there's more than just the three, and we'll discuss others as well, but these are like the ones most people will know: cross-sectional studies, cohort studies, and case control studies. And cross-sectional studies take a snapshot in time of a population and then look at the outcomes of interest in that population. For example, disease prevalence, and they look at exposed versus unexposed. But what you also can do if you really want to follow up longitudinally is you can do a repeated cross-sectional design where you take cross-sectional snapshots and place them on a time axis. What it doesn't allow is to then make a causal inference based on that. But really important studies have been done using just cross-sectional designs, and I think it's an important and a really relevant and impactful method, as we'll see. For example, the study by Vanderstichelen et al. In 2017 looked at indicators of receiving appropriate end-of-life care for the entire population that died from cancer in Belgium in 2012, and looked at the use of those indicators, or the presence of those indicators, at different time points before death, until death. This is a study I'm sure you'll be familiar with, and I hope I don't say anything wrong about it because I saw who was in the audience right now. But it can also be used to make really important and impactful projections such as this study by Catherine Sleeman and colleagues that showed that 48 million people are going to die with serious health-related suffering annually by 2060, an increase of 78% since 2016. Those are really impactful results and insights that can shape policy. So cross-sectional studies can really help us make important projections as well. Cohort studies, I think you'll be familiar with. What we do there in cohort studies is divide our population into two groups, exposed versus unexposed, and we'll follow those up in time longitudinally. And then look at for example, disease incidence at the end in the two different cohorts. And so cohort studies have also been used in public health palliative care research, for example, to study the connection between the Compassionate Community Initiative in Frome, Somerset, the connection between that initiative and unplanned emergency admissions and admission costs. And this study by Julian Abel showed that the initiative, Compassionate Community Initiative, was shown to decrease unplanned emergency admissions in the entire region of Somerset. And then the third big one is case control studies. Looks similar, but kind of flips the idea around, and it starts at the end. So you'll have a group of cases and a group of controls, and then you'll look back in time and see how many of the people in the cases in the case group were exposed to the variable of interest versus unexposed, and the same in the control group. And you make inference based on that. And case control studies are more frequently seen in clinical research, but they can be really useful for public health palliative care research as well. For example, big data studies that make use of existing administrative databases, they often use this design. For example, comparing people having received palliative care in the last months of life to those who did not have access to palliative care in the last months of life. And an example of this is a study by Martens and colleagues. And in this study, people who received palliative care, palliative home care support, rather, were matched to those who did not, based on individual estimations of their propensity for receiving palliative home care support. And even though in the title they mentioned a cohort study, the methodology they used actually was a one-to-one case control propensity score matching. And their study found that the use of palliative home care support positively impacted quality of care and reduced total cost of care at the end of life. So as you'll see, these observational methods are really useful in public health palliative care research and can have impactful results for policymaking as well. But there's other methods in the observational research designs. For example, document analysis, interview studies, and ethnography. When I say document analysis, I'm not sure what will come to mind, but often we overlook some really important methods that we have at our disposal, one being the literature review. Systematic literature reviews or integrative or narrative or scoping reviews, all very relevant to synthesize, summarize the vast amount of work being done in this field of research and in what is still public health palliative care research, a developing domain. So they can be really useful to get the state of the art, see where the gaps lie, see what the evidence is, where it mounts to. And I've just picked two papers by colleagues of mine that did a systematic review first of area-based compassionate community, so compassionate community initiatives that are defined by geographic boundaries, so compassionate cities or municipalities or schools even, I think, are in there. And then a second review focused more on civic engagement initiatives in serious illness, death, and loss. So also compassionate community initiatives, but not ones that cross geographic boundaries and not really defined by a geographic area. The image on the right is from the second study showing the spread and the emergence of these kinds of initiatives across the world, and they looked at the evidence and the quality of evaluations that have been done. Another one that you may not immediately think of, and I think is way underused in our field, is the meta-analysis. But you may recognize this slide. It pops up a lot in public health palliative care, and I know Libby Snell now uses this slide a lot with good reason. It's from a study by Holt Lundstad, and they showed that social relationships among people with several conditions associated with mortality had the strongest protective effect on mortality risk, stronger than smoking cessation or abstinence when considering alcohol consumption, or the flu vaccine, or BMI. And what was interesting about this is that they showed that it was complex measures of social integration that had the strongest effect. So we're not talking about just how many people live in your household, but this is really about wider social networks of support and community and social roles. So the next step, I think, for the field is, and I do believe people are working on it, would be to see what the impact is of social relationships on health and well-being at the end of life or after loss. An example of a interview study is this by Max Kleber and colleagues, and this was a report on an initiative that they developed where they set up community-based intergenerational arts initiatives on death and loss, and they basically had older people and children come together, use artistic arts and crafts or artistic mediums to talk, discuss, and exchange about death and dying and loss. And what was interesting through this interview study, they were able to show that it was actually the adults in between, as they called them. So basically, you and me. So not the children and not the older adults, because they were fine talking about death, but it was the adults in between that had a sort of power over that interaction and the responsibility that they felt for those children and the older adults participating in those interactions. And that added a layer of complexity. They had the most difficulty with these interactions. And it shows what kind of dynamics can play in making death and dying discussable or raising awareness about it or have people engage with the topics. And then finally, ethnography, a type of field research originating from cultural anthropology. And it examines behaviors of participants who represent a particular in-group in a natural setting, and it's interested in understanding their interpretation of their behavior. And so to that end, it often uses participant or non-participant observational methods of data collection. And it's not as prevalent as other research designs in public health palliative care research, but it can be a really appropriate design to track and identify the processes and relationships through which events, practices, and things become meaningful, and how behavior can manifest itself in certain contexts, for example. And this is an example of such a study that looked at the manifestation of existential suffering at the end of life by Rens et al. Fear, pain, denial, and spiritual experiences and dying processes. And the next big group is experimental research designs. And we'll actually be quite brief about this because this is a difficult one for public health palliative care research. So experimental research focuses on the manipulation of an environment and then to test hypotheses and, if possible, to establish causal links between predictors and outcomes in a particular setting. And many different types of experience are possible, as you'll probably know, various levels of control, randomization, and complexity. And it's popular in clinical research and held to as a high standard or gold standard of evidence. But actively manipulating independent variables may become kind of impractical and unethical when it involves human subjects in a natural environment rather than a laboratory setting when you're dealing with communities. And so they're useful, as we'll see two examples, but rare in public health palliative care research. Also because not only the practical and ethical aspect that may play a role, but they also represent a static linear approach, which doesn't gel well with the implementation of interventions in a natural setting, because it also assumes that the intervention can be optimized prior to implementation, which in public health palliative care research, when it comes to complex interventions, and that a lot of those designs belong to the next category, that's not really how it goes. Usually, interventions require optimization along implementation, and also means that the intervention will change and that the outcomes or the shape that they take will change, and that there's a lot of emergent and unpredictable effects or outcomes that may take place. But control trials do have their place. And so, for example, on the left side, randomized control trials have been used to evaluate health system outcomes of social and practical support interventions for people with life-limiting conditions. Our non-randomized control trial, as on the left by Liberada Flores and colleagues, has been used to evaluate the impact of care networks on health outcomes, including quality of care, caregiver burden, place of death, and resource use. But so that's why we're being brief about the experimental designs, because their applicability in public health palliative care is limited, but they are used in certain situations. But more often, we will see change-oriented designs. And so in change-oriented research designs, the boundaries between researcher, research population, and setting, and between intervention and context, they're often really blurry and sometimes straight up non-existent. Researchers themselves will often partner with the setting and become part of the intervention. And so participatory action research, and particularly in the new public health stream of palliative care research, it works on the principle of co-creation. And so participatory methods are particularly useful to bring in perspectives of those affected by the intervention in which they're involved and to evaluate conceptual outcomes of interventions. So in PAR, for short, participatory action research, those directly affected by the intervention are not only involved in evaluating it, but frequently also in the design, the development of the study, and the implementation process. So the design has been used to engage difficult to reach and indigenous communities for that reason, that have limited access, for example, to medical services to develop palliative care programs. And the image on the bottom left is from such a study by Kelly and colleagues that we'll talk a little bit more about in a minute. But it's also been used to examine advanced care planning, peer education through volunteer perspectives on training and community engagement activities in a study by Seymour and colleagues from 2013. It's been used to explore power dynamics in and creating spaces for community engagement and end-of-life issues through intergenerational arts initiatives. And that's, again, Max Gleibach and colleagues that worked on that. And so participatory action research is a really popular design, particularly in the compassionate communities literature and movement, because strong and close collaborations with local communities are core principles in those. One of the often used models, a lot of these change-oriented designs take a social ecological perspective on initiatives and on change. And on the left side, you see the Circles of Care model by Julian Abel and colleagues. And it's useful in several ways in recognizing the embeddedness of the person with care needs within an inner network, their outer network, community, service delivery sphere, and policy sphere. And there's different levels possible. You could add more to those and in between, depending on your specific research question. But they're also very useful to understand the influence of certain phenomena, certain initiatives, certain variables or effects between these different spheres of influence. So how something from the policy level influences the person, through which spheres of influence it has to go and what interactions that creates, and how it interacts, for example, a policy change, how it interacts with the service delivery sphere, how that interacts then with the community sphere, and eventually finds its way to outcomes on the individual level. And so these kind of models have been used quite frequently. And one example is, again, the study by Kelly and colleagues that looked at developing palliative care programs in Indigenous communities in Canada using a participatory action research design. And they adapted Julian Abel's model and were able to embed the principal caregiving network, or rather found that this principal caregiving network consisting of the individual receiving care, but also their family members who provided, that it was embedded in first an internal caregiving networks, which consisted of the First Nations community, and that included, among others, extended family, community health services, knowledge carriers, elders and leadership, and community members that supported them in caring and assisted with caregiving. And that internal network was then embedded within an external caregiving network, namely Canada's healthcare system, and how those big three spheres of influence interacted with each other was then described in the publication. This is a compassionate cities model. This one is designed by my colleague Joachim Cohen. We've adapted it to a compassionate workplaces model, and that was published I think today or yesterday. When I first saw this model, actually, I didn't like it. I thought it was way too chaotic. I didn't understand it. But the more I've actually worked with it, the more useful and the more useful. I was going to say brilliant. I mean, that's going a bit far. I find it because it really helps understand. It helps both focus your research lens as well as your practice lens. And as I've said in these change-oriented designs, both research and practice are nigh indistinguishable from each other in many cases. And in this case, it helps us think about what key principles of community engagement to use to reorient settings through the engagement of target groups, and helps us link what specific activities or actions can be appropriate for specific target groups according to those key principles, and then linking that to a specific environmental focus. That's for implementation, but on the other hand, it also helps us think for each of those levels of implementation focus, what outcomes, outputs, and inputs and success factors figure into an evaluation model. Now, this is a compassionate cities model. This is a very more, not entirely, but more top-down model for reorienting settings to create kind of a playfield for existing social networks and existing resources within a certain community setting. And there's also bottom-up models, such as the ABCD models. And I just picked these two images to kind of give you an idea of how those, first of all, the new essentials model just kind of shows how these different types of models are connected to each other, and that they all, a recognition that they all play a role in creating change. But I like the model on the right, and I forgot to credit them on the slide, but this is from the Transform platform for integrated community care online. And I like this one because it shows or recognizes the, and helps us think about how to position all these different elements in the community and in the healthcare system towards each other around the patient and the caregivers. And it recognizes that healthcare and professional services play an important role, but are one aspect of a larger community whole. And it can help in these disparate action designs to craft priorities, craft short-term actions within a community that address all of these different factors. Just to give you an example of a change-oriented research paper, this is a famous one, Bringing Our Dying Home paper by Debbie Horsfall, Carrie Noonan, and Rosemary Leonard, which laid the foundation for the death literacy kind of literature and movement, if that's the right word. And it showed how informal engagement in end-of-life care and support led to network growth and increased network density of people receiving care, people giving care. And it kind of showed the transformational capacity of such informal engagement and experience. It transformed itself into kind of a resource that was able to be shared and leveraged later on in consecutive or future engagement or experiences of end of life. And that laid the foundation kind of for the idea of death literacy as a resource in a community. So as you'll have seen, especially with the last big category, is that it's with each step we kind of increase in complexity, and a lot has been written about complexity, but it is worthwhile just taking a second and thinking about what it is and what it means for us. So several definitions of complexity do exist, but most will indicate that it's an emergent attribute of a system or intervention that's caused by interaction of multiple parts, but also by the variability in those interactions and the unpredictability in its outcomes. However, others argue that even more than just a function of interaction between discrete elements, complexity should be seen as a dynamic and constantly emerging set of processes and objects that not only interact with each other, but also come to be defined by those interactions. And that last part is really crucial because it acknowledges a feedback effect in complex systems and complex interventions. And complex interventions can't be described by linear pathways between the intervention and outcome, simply because they're often embedded in complex systems, in natural environments. And they're marked by nonlinear pathways, multiple confounding variables, and feedback loops between the intervention and context. So it's really important, all the more, to choose the appropriate methods or combinations of methods to deal with this complexity that experimental or change-oriented public health palliative care research poses. Aside from dealing with the complexity, your method should obviously also, it's also really important to consider what your research questions are, what you want to know, and what is possible to know. So this is just a quick recap. Because there's no equivalent of the sterile laboratory in public health palliative care research, and the fact that researchers and participants often end up taking on dual roles, it's hard to distinguish those, and so it becomes evident or clear that the intervention or the research can hardly be distinguished from the context, as both kind of bleed into each other naturally. And that makes it so that interventions are dynamic products that change during implementation and evaluation, and that makes it so complex to study. But complexity can also come from conceptual issues. For example, how do we measure health and well-being at the end of life? When do we consider compassionate communities compassionate? There's a lot of conceptual questions we can ask on these topics. For example, health, well-being, impact. Maybe if we just focus on health first, how do we even define health? And maybe these are tired questions, but do we define it as a function of physical or mental functionality or ability? And a lot of people will then say like, well, yeah, that seems reasonable. And then you realize, oh, when I'm old, and according to this definition, it's impossible for me to be healthy anymore. So that's problematic. Is it absence of illness? Sure. But then we remember illness depends on the definitions that we have of illness, and those definitions change, phase out. Just one example, homosexuality used to be considered an illness. It's not today. So, okay, also a problematic definition. Maybe we can define it by proxy. Disease prevalence in a given population, mortality statistics, healthy behaviors, lifestyles, those can be measured. Yes, and yes, and yes. But then you're also only getting a part of the bigger picture that is health. And I think it's really important that we acknowledge that, and that we're also taking that into account when we design our research and when we're conducting this research, that we need to be really clear if we're talking about health outcomes, what are we actually making conclusions about? Another one is impact, which is also kind of a buzzword, and how do we capture it and compare it? But even if we define it quite well, and there's models for that and methods like ripple effect mapping, co-impact is also, I think, a whole model of impact measurement. But even if we define what we consider impact to be, public health palliative care intervention studies often require such long time frameworks to develop, implement, evaluate. It can take a long time before any effect or impact can even be observed or registered, which is also something we need to consider. And moreover, a lot of these initiatives often look for a sustainable and a structural change, right? And that can take a lot longer time than funding agencies are prepared or even capable to support. So we also need to take that into account when we conduct research. And I think this is broader than just research. This is probably an argument or a discussion to be had by the entire scientific community, and including funding bodies, to an item to consider there. Complexity can also come from scale, right? So conducting studies in real life contexts confront researchers with dynamic environments. So for example, recognizing different perspectives in a community, unanticipated outcomes from an intervention, evaluating processes that underlie these transitions, adaptation of the intervention over time. And in the same way that interventions can be complex in that they have numerous components that interact in multiple unpredictable ways, so too are the systems that they're implemented in, right? They're also complex systems. So the introduction into a natural setting of even a simple intervention, and let's say that simple intervention is we're changing a law that affects the price of products that affect health, that can cause cascading emergent unpredictable consequences that can change the system and then create further changes in the system down the line, and that can change your intervention again. So some challenges I've seen that can help us face that complexity, perhaps, that I think at least are worthwhile exploring. One of them is developing and validating tools and instruments that allow for cross-setting comparisons and that allow to measure common components that several types of interventions or initiatives strive at, rather than comparing directly specific outcomes that can be quite differently operationalized or chosen in different initiative interventions. And the Death Literacy Index is like one of those examples, and I've chosen this one because it's a field that I'm doing work in now. But I've chosen that as an example as well because the kind of purpose of the instrument, at least, was also to measure the generation of capacity in a community that can be reasonably expected to be the result of general health promoting palliative care interventions or initiatives. And that can be one way of comparing the effectiveness or the impact of such initiatives, regardless of their specific aims or outcomes. Another is to employ methods that capture processes or emergent outcomes. And I think we have a lot to be inspired by from the implementation sciences. One of my colleagues has done some work on this and looking what are the appropriate and valuable implementation frameworks to be used for example, compassionate communities and cities initiatives, how to evaluate those processes. Or employ methods that allow for narrative or quantitative comparison across studies, such as meta-analyses. And all of these are obviously difficult, and attempts will never really be foolproof or perfect, but comparative analyses are really worthwhile, I think, and we're in dire need of them. And then finally, participatory, I think in the past has been by some considered to be kind of a dirty word, or kind of make sure that or kind of implies that your science is not rigorous. I think that's not the case, but I think it's a big challenge to deal with that double role that researchers can have, and to deal with the fact, finding ways or methods or frameworks to deal with intervention and initiative evaluation studies where the context and the intervention are just non-distinguishable from each other. How do we then make meaningful conclusions? But a lot of valuable insights can come from participatory action research or even participatory observational research. So wanted to end on that note. With a final, I'm going to skip this. You can get the contact details. They're here too. Once anyone's interested, it's not confirmed yet, but we've applied for an open meeting with our reference group on public health palliative care. We're hoping to do a really cool kind of Pecha format to see what kind of work is being done, hear stories from not just researchers and not just dry research presentations, but also get the stories from people working in practice, in policy, about meaningful change that they've effected, or other stories they think is meaningful to tell. So if anyone's going to the EAPC next year and doesn't know what to do during the open meeting slots, you're very welcome to join us there. Thank you.
Thank you, Stephen, for a very comprehensive presentation of a variety of ways to explore palliative care as a public health issue. I'll leave. Does anyone have any question? You are free to post them in the chat. Yes, it's Richard.
Thank you so much. That was truly brilliant. Really, really enjoyed that. So my question is about culture. I mean, from our looking at the literature, I think the thing we found most surprising was that probably many of us would trace compassionate communities back to India. And yet, when we look at the literature, it's almost exclusively from high-income countries, which are developing and evaluating models. Stuff from low-income countries isn't really represented in the literature and isn't being evaluated. So I just wondered your thought on that imbalance. For an idea that came from India, we don't seem to have much balanced evidence, and also the meaning of culture within high-income countries as well, with increasingly diverse urban populations. Thank you.
Thank you, Richard. I mean, you're fully correct on this, and this is something that has been discussed, I think, by a lot of people working public health palliative care. But it's true. The model came from Kerala, but it has been kind of co-opted by higher income countries. I think part of that might have to do with first of all, who's doing the research, and I think it's just a representation. I mean, if we look at who are the researchers who are at least getting the most airtime as well in like international in like the international field of research on this, it is mainly people also from higher middle income countries or higher income countries. I think something interesting, at least I've noted, I don't really want to say that this is a reason, but this might play a role as well, is that we find that, and it's also, from what we know at least, mostly in higher income countries where death has been so strongly medicalized, and that care and support for the end of life has been sort of outsourced to professionalized services. I think it's also Ivan Illich that talked about the hospitalization of death. Whereas in many lower and middle income countries, we find that a lot of these compassionate communities naturally exist and don't need to be kickstarted by researchers, or that these, I think, support networks exist and are being used, partially because there's then a lack of access to specialized professional palliative care. So there's like an interesting dynamic there where a lot of higher income countries have lost the resources in the community because their palliative care provision has been so advanced in a sense that our healthcare systems are so advanced that everything's been professionalized and outsourced to professionals. and that in those middle and lower income countries, a lot of them depend on these informal support networks where palliative care access is not what it should be. Due to a lack of infrastructure, due to a lack of resources. So I think that plays a role, and that we've now kind of think that we've invented this and we've coined it, but it's not, compassion communities are not so new. The term is new, but the idea is as old as time, I think. And that lack of recognition and acknowledgement is concerning. I agree. I don't really know if there's I have a really good argument or solution for this. I think it's something we need to face as a community of researchers and be able to, I guess, valorize or evaluate or validate more the models that have been and exist in communities worldwide, but maybe just are rarer in higher income countries, and now we have to invent terms and reintroduce them. Yeah.
Thank you for that answer. Okay, question from Catherine, or a comment. I can't hear you.
I saw you unmute yourself, but it's still silent.
Yeah,
I'm afraid.
You seem unmuted, but okay. I can ask a question in the meantime, maybe. And I'm thinking about the do you think we are moving towards a quantification of the more community-based focuses in public health palliative care, where you discussed, there's a lot of emphasis on complexity, and there might be a strong influence on cultural contexts, but there's also a push towards creating these kind of neat, easily comparable outcomes. Do you think that we are heading towards a quantification that might not align with how these research endeavors originally started?
That's a good question. I mean, yes. The short answer, I think, is yes. We are going to kind of a quantification of, because there's from communities, we also notice this, and maybe this is not the best answer, the quantification and striving towards more comparative quantitative methods. But the demand from communities is very much for evidence of that what they're doing works and that they're making a difference. And in many ways, you can show that qualitatively more meaningfully than you can show in numbers. I firmly believe that. I've seen evidence of that, but I think part of the problem, or part of the consideration there, is that policymakers don't necessarily listen to qualitative evidence as much as quantitative evidence. So there's this tension field there, that you kind of need to speak the language of those who are funding some of the work or supporting the work. And I think community developers, practitioners also feel that need. They want to see somehow that what they're doing has an impact, and we generally evaluate numbers more than experiences. But I don't think in research that it's really gaining a problematic upper hand. I think a lot of qualitative research, and a really important qualitative research, has been done and is being done at this moment, because we also realize that a lot of the, for example, causal attribution can't be done without qualitative evidence. So I think there's a growing recognition of that. So I don't think it's necessarily problematic, but we shouldn't stare ourselves blind at trying to create numbers or like instruments that capture things in numbers and think it's then showing us anything meaningful. We should always be critical of that, I think.
Thank you. Okay, Catherine, do you want to give it a try?
Can I try again? Is that working?
Yes, and I can hear you.
Oh, thanks, Stephen. That was such a good talk and has given me a lot to think about, although I've got a couple of questions. I'll ask one and maybe another one after. Okay, so one of the things I was wondering about, because it's quite difficult for me as a kind of really traditional doctor, medic, palliative medicine, kind of straightforward academic, it's some of these concepts are quite difficult for me to get my head around, and it's a very broad question, but does this distinction between traditional public health and new public health approaches exist in loads of fields, like, primary care or is this a kind of particular thing that palliative care is exploring?
Ooh, I'm not sure if I can give a good answer to that. I
could maybe comment a little bit.
Yeah.
I would definitely say that this is something that stems from general healthcare. So this, with the whole Ottawa Charter, which was broad healthcare needs. So this comes from healthcare in general and has been applied to a palliative care setting, where it maybe has gained even more traction because you have the whole taking care of your dying in society that has it's more embedded perhaps.
And the influence definitely of community engagement practices and movements definitely exists in primary care and in formal care. Like the caring neighborhoods movement was a thing, I think, that goes back a bit further than compassionate communities. And those compassionate, like, I mean, new public health approaches aren't only compassionate communities, right? So that's only also a part of that. Just want to acknowledge that. But it is a very prominent part of that now. It's very visible. And the whole compassionate cities term was actually just coined to add death and dying and bereavement to those caring communities movements. Where we noticed that no one there was really, for example, age-friendly communities and aging in place. Those are all older, I think, and none of them were talking about dying. So they're all talking about how to live well and how to live meaningfully in older age and how to take care of our older people. But when it came to acknowledging that, well, once you get older, you're also more likely to die, no one wanted to kind of touch that. So I think that the distinction between the two approaches, I'm not sure how translatable it is to other fields, but it's definitely something that was borrowed from outside, if that makes sense.
Yeah, thanks. Really interesting.
Okay, I'll read a question from the chat. So do you see examples of how the research is contributing towards a change in policy and practice? Is the first question.
Yes. Yes, actually, I'll speak for Flanders. So yes, because we know that the reorganization. So currently, there's a reorganization of palliative care happening in Flanders. Well, it's on hiatus now because of elections, but there's a movement to go to a more public health approach, and that has definitely been inspired by the public health palliative care kind of movement and research. And when we talked to policymakers about this, because we were asked to develop an evaluation plan for that restructuring. And I worked on that personally with a few colleagues. There was definitely a sense of urgency on how important these public health notions were, and it has led to it has been framed as a part of a broader restructuring of I guess primary care, integrated care. It's been kind of linked to that. But also even more specifically and more concretely within the compassionate cities, there has been specific. I mean, I can't really cite specific policy changes, but the way the city of Bruges now works on death and dying, I mean, that didn't exist before Compassionate Bruges was kickstarted. So there was definitely a desire to work on those topics, but they've really developed several policy initiatives. Within Bruges, within Herzelen, another compassionate city. I can also give but maybe that's not the level that you're looking for. But for example, the University of Brussels has also tried to develop itself to a compassionate university. There I can give a bit more specific examples of policy changes, but and a really trivial almost one, but an important one was in the university, if a colleague or a student if a colleague died, you couldn't send flowers because that was sending gifts to colleagues, and that was not allowed. And that was such a absurd reasoning, which the university recognized quickly, and we got that changed. And now you can send flowers as a token of your sympathies to a colleague who had someone pass away, or if a colleague passed away, to their family. That wasn't a possibility before, and it's like small little things like that can make a workplace at least more as a warmer and more supportive environment. There's been scripts for leaders, for leadership supervisors, how to deal with a student dying, or teachers for how to deal with a student dying. There's commemoration practices now when students graduate, graduation ceremonies. There's now time taken to recognize students that may have died, if that's the case, and it does happen. There's also shows of there's also commitments, like when we have the academic opening yearly now has, as of a few years ago, has an empty chair to recognize and commemorate and remember the people that we've lost in the last year. And initially there was a lot of pushback against it. And it was our late rector, Caroline Pauwels, who really pushed it through together with the Compassion University Project, saying that we need to do this. A lot of people thought, it's going to be such a bummer. It should be a festivity. It should be happy, the opening of the academic year. And then it turned out to be a really memorable and nice moment. And now they're doing it every year, where people feel seen. The people are not there that should be there. And usually it would just be brushed over and no one would talk about it. And now it's actually something that is publicly recognized. So there's all small changes that I've noticed in the university, but definitely on a city level and on a regional level in Flanders, there's real policy change in the works based on these ideas and these practices. So that's really cool to see up close.
Interesting.
Sorry, I'm giving very long answers. I apologize.
No, it's interesting, and I'm wondering whether any of these policy changes might give opportunity to do like natural experiments. But I'll hand over to Catherine, and then we also have another question in the chat.
So I was going to ask about death literacy, not the DLI specifically, but just death literacy, because I've been in palliative medicine for, 15 or more years, and I see so little change, so little improvement in terms of death literacy generally. But what there has been over the past decade is an enormous amount of kind of quite high profile books and TV programs and this, that, and the other that is all aimed at helping. But then what I see in practice is actually still huge myths and misconceptions and lack of death literacy. So I wondered, I suppose quite specifically, do you know of what is actually helpful? Which are the interventions that work and work for different communities?
That is also a question that I have. I'll be honest. It's part of the work that I'm doing with a PhD student of mine, and that we're hoping to find out whether, for example, educational interventions can actually help, and how long and lasting that effect is for a group of people. Because it's hard to estimate what really works, and sometimes it's the cumulative effect of very small spread out changes, and it representation. I think what we know from the other areas is that representation definitely has an impact, but it can be slow, but it can be a start. If people feel seen, I believe if people feel seen and recognized and see their experiences or just the topics or questions that they're struggling with around end of life represented in media and in the public space, they won't feel alone. They will feel like, oh, it's not just me wondering about this, and oh, this is something other people go through, and it will lower the threshold maybe to talk to someone else about it. And I think that's change that goes very slowly, but I do think it's happening. But as to the question, what are the interventions that really help? Anything that works on, I think, representation is a good bet. And it remains to be seen whether educational interventions, more formal educational interventions, whether that actually has a lasting effect. I think it can have a short-term effect, but I think really you need to put it into practice afterwards for it to stick. And then there's always just that. There's never 100% that sticks. It's always a little bit, and it's identifying what those crucial bits are that need to stick. But that's, I think, a work in progress. So I can't give you a real good answer to that, but it's a very good question, an important question.
I'm glad you've got your PhD student on it.
Yeah.
We'll invite you to another seminar session in a few years then to provide us with an answer. Okay, so we have a question that is embedded in a comment, so I'll just read out the whole thing so that I'm not kind of misinterpreting the question. There are community development workers, artists, and non-researchers who take similar approaches to participatory action research or art-based research methods in terms of developing intervention around death, dying, loss, and bereavement, particularly when these non-researchers might already be embedded within communities who are traditionally underrepresented in research. How can the research community work with or learn from these projects? For examples in terms of evaluation, sharing of good practice, disseminating research findings in ways and places that non-researchers access.
Also a really good question. And it's also a thing that we've been working on within the Compassion Community Center of Expertise, as we were funded by interdisciplinary research programs. And among our consortium are also arts, educational scientists, and so artists. And we've worked with artists. The bigger problem here, I think, when it comes to research, is that it's so hard for people to, for all of us, honestly, to look over our domain or disciplinary boundaries. And even if we manage to look over the wall, we don't really know what to do with what's on the other side. And that requires time and effort. So I think an outspoken or explicit commitment to interdisciplinary work with community and so with practice and with researchers is a must. But that requires time to get. Actually, the best thing you can do in that case is and I've learned from experience, is taking time to get to know each other first and foremost, and make sure that everyone that you talk to sees themselves represented in the work you're doing together. And only then can you start working together. And that takes quite a long time. It took us, for a consortium of, I think, was it 8 or 9 groups, some of which were closer to each other than the others. It took us at least 2 years to even get a start on that. But the investment paid off. So it needs to be on equal footing. So whatever framework you're trying to get this to work in, it needs to be on equal footing. Everyone needs to have an equal share in the role. But it's important that there's a dedicated staff or a dedicated coordinator, whatever, someone that makes sure that everyone feels recognized and or recognizes themselves in the communal work that you want to do. If that's not the case, they're gonna not stick around. And that was one of the things that Coco in the beginning was very difficult, because we clearly wanted to do something on compassionate communities, and that was from like social health sciences, and the educational scientists, adult educational scientists, were working on social gerontology and caring neighborhoods, so they got it as well. But the others didn't. With each other group, it was, yeah, but that's the thing you're doing. We don't really work on that yet. And we had to go and look and say, like, well, is that really true? Like, look at this. This is how we see that working with, or see that related to the work that we're trying to do. And this is what we want to learn from you. And I think this is missing in the work that we're doing. And that just took a long time. But everyone afterwards, everyone was on board. And so, yeah, commit time and resources to getting to know people and recognizing each other in the work you want to do together. That's the first step. If you don't undertake that, it's just not going to work.
Thank you, Stephen. So it is time to conclude the today's session. We have the next seminar taking place on Wednesday, the 23rd of October, and we have Professor Linda Lee from the School of Nursing and Health Sciences at Hong Kong Metropolitan University presenting, and she'll be sharing her work on rehabilitation, a contemporary approach to support the continuum of care from aging in place to dying in place. We do have an evaluation form that we will post in the chat, and it is also possible to join our mailing list. We'll link or send a link to that in the chat as well.